Welcome back. I'm Dr. T. So, have you ever had a patient and you look them dead in the face and they say, Doc, it doesn't matter what I do, this happens? I've noticed a theme. I feel like a lot of my patients have what I think PTSD, just like and very negative self concept when it comes to diabetic foot ulcers until like they finally see it healing and improving. But when we first start initially, it starts off most of the time very scared, negative. They expect the worst, and I don't want patients to feel like that, especially with diabetic foot ulcers. There is always something we can do. And maybe, you felt it in yourself when it comes to limb salvage and you're doing everything right, but the patient's also fighting insurance denials, they're missing appointments, late referrals. That's a really big thing. I've had a patient who had a late referral because the doctor can only see them like months later because they're really booked out. A patient having repeated infection, member thymus tissue, repeated debridements, repeated hospital admissions until the whole team start thinking, what's the point? Okay. The patient will start thinking like that. And this feeling has a name and it's called learned helplessness. And today we're going to connect the psychology behind it, the classic experiments, the brain, the science, and most importantly, the real healthcare version of learned helplessness that shows up in patients who have diabetic foot ulcers, chronic wounds, when limb salvage comes into play, and even when it comes to clinicians. Okay. Because learned helplessness is not a weakness, it's actually a predictable human response due to repeated experiences that are uncontrollable. So, again, welcome back to Diabetic Profiles, where we turn our pressure points into power and science into strategy, and we're going to fight the dark ages of unnecessary amputations. So, today we're going to learn about what is learned helplessness, the experiments that actually discovered it, the updated science behind it, and why we can control the changes in our nervous systems, how learned helplessness gets manufactured in the healthcare system, what it looks like for diabetic foot ulcer care, and exactly how we treat it in a patient, in the system, and as a team. So, what is learned helplessness actually? So, learned helplessness, we're going to do the definition and the controllability at core of it. So, learned helplessness is the state where someone stops trying. They literally just stop trying. It's not because they're lazy, but it's because they learned through repeated experiences, okay, that their actions don't change the outcomes. And I see that a lot, especially in wound care, because sometimes patients they have had really bad experiences in the past, especially even some hospitals will turn patients away. I've had a patient that went to the ER multiple times and they were like, there's nothing that they can do because she had you know PAD, and there was no doctor there to help her with that. They just kept on saying, "Just follow up privately," and this lady has pretty much no circulation to her legs. So, they kinda give up even though they went to the ER because that's where you go, right? Where you don't know much, but you know that your loved one or you need help, you go to the ER. But if the ER is turning you away, what are you supposed to think, right? And this usually shows up with patients saying like, "Why bother?" Or, a low follow up through, like they won't follow up as much, passivity, reduced problem solving, emotional shutdown, and depression like symptoms. I'm always happy when I notice my patients start feeling positive about themselves. And you can see the change because honestly, it's like night and day. I always tell people it's like night and day because when you see them initially, they do feel like they're emotionally beaten and exhausted by the healthcare system because they still have this open ulcer that they've been dealing with for months or years, even. But the key idea is that it's not that something bad happened, it's just that the person experienced a bad thing as uncontrollable. And a chronic diabetic foot disease is basically an arena where people get hit repeatedly with unpredictable setbacks. Doctor might say, "Oh, you have osteomyelitis, we might have to amputate," things like that. Complicated instructions because they do get complicated. You're going to have multiple referrals, pain and neuropathy. A lot of people don't feel like it's that dangerous because they don't feel that they don't feel it because of the neuropathy, okay? So the danger doesn't feel real because they can't feel that well with the neuropathy. Social and financial barriers, that is a big thing when it comes to wound care. Some people don't have the money to invest in wound care. It can be very pricey. Inconsistent access, and then the scary outcomes like hospitalization and amputation. When patients hear hospitalization or amputation, a lot of them do get scared, okay? And this is a fertile ground for helplessness. So that's why I'm always proud of every patient that I see and they fight for themselves. I'm very proud of everyone. It is worth it. You have to advocate for yourself. So the experiments on how to discover helplessness. Okay, so the earliest learned helplessness research came from experiments where animals, okay, were exposed to stress that they could not control, okay? And later, when escape was possible, they did not even try to escape because their brain concluded that the action won't work, okay? This is a line of work strongly associated with Martin E.P. Seligman and Stephen Mayer, and it's become a foundation for understanding how perceived control shapes our behavior and emotion. So let me translate what matters clinically without, it getting lost in the weeds. I can talk a little bit more about the experiment. So I believe they used dogs, okay? And so they put the dogs in a shuttle box experiment, and there's 3 groups. There's a control group where the dogs were placed in a harness, right? But no shocks. They did not receive any electrical shocks, so nothing bad happened. Then there's group 2, the escape group, and these dogs received mild electrical shocks, but could stop them by pressing on the panel with their nose. So they learned that they can control this, like they can stop the electrical shocks with their nose. And then there is group 3, the no control group. These dogs got the same shocks, but regardless of what they were doing, the nothing would stop the shock. So they learned that nothing I do matters. And so there was a next phase. So all the dogs were placed in the shuttle box where there was a low barrier in the middle where they could jump over, and the shock was on one side, and the safer side had no shock, so they could jump over. And all the dog had to do was jump over the barrier. So, they were placed in the barrier where the side where there are electrical shocks, right? And if you jump over to the other side, there is no shocks, right? So the control group that got no shocks, they jumped over immediately because they got shocks on one side, they jumped over immediately. The escape group that learned, remember, if they pressed down, the shock stopped, they jumped over it quickly. But the control group, the no control group, the group that was placed in the shocks, right? They got the shocks no matter what they did. They got shocked even if they tried to move out the way, they got shocked while they were I think they were still in the harness, but pressing, nothing that they did mattered. Those dogs literally did not move. They did not even try to jump over the little area to the area where there's no shocks because so they just laid down and whined. So they literally whimpered and didn't even try to take themselves out of the area where it was shocked because they learned that I have no control, so trying is pointless. And that's kind of sad, but it's actually, experiment that shows that this is neural behavioral shutdown, unfortunately. So what is happening in the brain? So this is repeated uncontrollable stress changes the brain circuitry. So there's lower dopamine. So dopamine helps for motivation. That's your motivation chemical. The amygdala activation, that's the area of stress and fear center that goes up. And then prefrontal cortex activity that goes down. That's your decision making and problem solving area, okay? And then your HPA axis dysregulates because of chronic stress that causes chronic stress mode. So your brain literally shifts into this conserve energy mode, do not even attempt to escape, and survival mode, unfortunately. And humans show the same pattern. If a person is repeatedly experiences failure, pain, medical trauma, poverty, chronic illness, and systems that don't respond to help them, they may develop passivity, low motivation, why bother mindset, depression, and reduced problem solving. I'm always impressed by my patients who do make these little at home makeshift things for their wounds. It's very impressive. They'll show you like, "Oh, I made this. This makes it much easier." I'm always proud of my patients. But patients really notice if they're getting better or not when they're coming to see you. So, like I said, if when somebody repeatedly experiences, I tried, but it didn't help. I did what they said, but it still got worse. I took off work to come here and they canceled, or I called but nobody answered. I wore the boot and it still got infected. These makes your nervous system learns that despite your effort, there's no outcome. And so the effort shuts down, and that's a mechanism, okay? But researchers didn't stop at the animals. So human studies found similar patterns. Like I said, after uncontrollable adverse experiences, people show impaired performance and reduced persistence, even in new tasks. So if you're thinking my patient is non-compliant, it really isn't. Sometimes what you're looking at is a learned response due to repeated defeat from the healthcare system of what they experienced previous to you. And like I said, I love seeing the change in their demeanor when they're seeing the wound getting smaller. Then they become more compliant. Like I told you, I've seen my patients walk through the snow. The train doesn't work no more, and I'm like, "Oh my god." I had a patient who was always on time. He was never late. This man, he he was just happy to keep his foot. He stayed in that booth, he even walked in the snow to get to his appointment on time, and I was just like, I wanted to cry sometimes because no matter where my company stationed me, because I was always at a different location every day at this company, my patient, he was there. He was there 3 times a week. We worked through it. And unfortunately, when I went on vacation, he, like, texted me. He's like, "The doctor didn't even wanna change my thing," and all this jazz, and I was just like, "Oh my gosh." Like, that's why I here's the thing. This is exactly why Gabby gives her patients her cell phone number, okay? Because I wanna know the truth. I don't want anybody telling me he said, she said, "Oh, the patient didn't show up. Oh, the patient didn't do this." Because one thing I do learn, my patients don't lie. They don't lie. They'll tell me the truth, okay? And I think they like to know that, yes, this doctor does believe me, because they'll tell you right away, especially when they start healing. They care about their wound dressing. They wanna get this thing closed, especially when they start seeing results. They will get results, okay? Especially when they see that you care as well, okay? But n that was just a side note. Okay, so the upgrade. Why some people generalize helplessness and while others don't, okay? So people tell on themselves, in all honesty. So a major update came from this reformulation of learned helplessness from, I think, Abramson and Teasdale and his colleagues. So they emphasized something powerful that when bad outcomes happen, people ask why. And that type of answer matters. So people are more likely to fall into a deeper helplessness when they interpret the setbacks as this will never change, or this ruins everything, or this is my fault, I'm broken. Please don't ever think that. Don't ever think this is your fault. This is not your fault. Okay, we can fix this. Okay, but in diabetic foot ulcers, that sounds like the patient will think my body doesn't heal. Nothing works for me. I did this to myself. Don't ever think that, okay? That's what healthcare providers are for. That's what we're here for, okay? And this becomes this self-reinforcing loop, unfortunately. So the patient experiences shame, avoidance, worse outcomes, and then more proof. And then so they have a deeper shutdown. So, the brain science controllability changes the stress response. So, why control in medicine matters. And I try to give my patients that is one of the parts of ethics when it comes to medicine. Remember, the patient maintaining their autonomy. Okay. So, modern neuroscience works on stress and controllability, argues that having control over a stressor changes how your brain responds. Particularly circuits involving the prefrontal cortex and the brain stress systems. So, if a patient experiences care as a as chaotic, confusing, punitive. Stress rises, learning narrows down, and their follow through drops. But if the care creates predictable steps, small wins, I always celebrate our small little wins, okay? Clear choices, fast feedback, visible cause and effect, then the motivation returns because the patient relearns what I do matter. And that is a big thing. What you do does matter. Okay. You have to do your part because, like you said, it's a multidisciplinary approach, and you're the most important part of the team. You're our sun. We're just the revolving planets around you, but you're the sun. You're the one that causes the gravity, right? You're the one who causes day and night. You're the one that matters the most, okay? So, how do certain patients learn helplessness in the healthcare system and how the system accidentally manufactures it, okay? So the helplessness factory, okay, when it comes to the patient side. So let's talk about how healthcare can create helplessness on a patient. So unpredictable access, okay, delayed referrals to limb salvage, long waits for vascular. I've had a lot of patients experience that. Inconsistent was not well in where I used to work. I had some of the most fantastic vascular doctors that I worked with. I would just be able to text them and they're like, "No problem, we'll get that patient in." That's what I need, okay? That's what Gabby needs all the time. I need that quick, quick, quick. Because 'cause I'm not gonna refer just out of nowhere. If it's non-emergent, yeah, follow up in a month, whatever. But if it's emergent, I need you to see this patient. I had the most amazing vascular doctors that were like, "No problem, see it, like, tomorrow," okay? And that's what happens. See, that's why I love me some vascular, okay? Not no come back in 2 weeks when the wound needs to 48 follow-up, okay? So repeated delays teach patients that no one is coming to save them, and I don't want a patient to feel like that. In medicine, we're all superheroes, right? And that's what we're supposed to do. We're supposed to be superheroes for our patients, okay? We try our best, right? If a patient hears, stay off of it completely, but also you must work to survive because I have a lot of patients that still have to work, right? Or you missed your appointment. This is a double bind teaches that the patient say thinking in their head, I can't win, right? Then medical medical language like lingo erases agency. So phrases like "there's nothing we can do." I've had a doctor say some really discouraging things to my previous family relatives in the past when we had a dire thing, like, "Oh, ooh, this surgery, I don't know if you'll survive," or stuff like that. And I'm like, who says stuff like that? I understand about realistic expectations, but patients take what you say very literally. So if you say, ooh, I'm not sure, yeah, the patient's not going to be sure, okay? Like, yeah, don't ever say there's nothing we can do, okay? It is what it is. Don't ever say that, okay? You're not a rap star. You're a poor candidate. You can rephrase that in a different way, okay? And then non-compliant, okay? Used to label that is used to label, but it doesn't problem solve. Don't say that because I've had patients that are non-compliant, don't take their medication. I get it. I understand. And I just ask them nicely, but can you please just for like 2 days and then follow back and we can see how it looks. Yay. Okay. So those words can, diagnose helplessness. Then a punishment based care. So if a patient expects to be scolded, if the patient is shamed, if the patient is dismissed, they avoid care. That's why I told people don't ever shame a patient, especially for like, let's say the wound smells or if they have maggots in their wounds or anything. Don't ever do that. That's not your job. And then if you're grossed out, I don't care. This is not about you right now, okay? It's not about you. It's about the patient. I don't want people to be like, "Oh my gosh, that crawls my flesh." I get it. We're all human, but right now at this very moment, somebody needs you. So you're not supposed to be doing that. It's not about you. So let's, take a deep breath in and take a deep breath out and do what we're supposed to do, which is help the patient, right? So don't ever scold the patient, don't ever shame the patient, don't ever dismiss the patient, make the patient feel like they're being dismissed, okay? Because that's what causes patients to avoid care and their condition could worsen and they'll feel helplessness. I don't want a patient to feel that. Let me tell you, I had some patients of mine, uh, I've seen the healthcare system unfortunately fail them, send them back, and then they end up with severe infection because I guess, like, they call them sometimes they call them frequent flyers, right? They'll say, "Oh, they frequently come to the ER, nothing's usually wrong with them," but that's still not an excuse. I get it, you don't wanna use up all the resources, they come too often, whatever, but still, sometimes you are wrong because 'cause I've seen it firsthand happen to some of the patients that I really, really care about, and if they had just treated it like a normal ER visit, do the full workup, at least draw their blood, could have saved their life, okay? And you know what? The bureaucracy of as trauma, the bureaucracy of healthcare and insurance. So things like prior authorizations, insurance denials, high copay, supply shortages. This causes repeated uncontrollable stress for the patient. And the patient brain does exactly what the brain is supposed to do. It adapts by conserving the effort. So, what learned helplessness looks like in diabetic foot ulcer care? Okay. And these are signs that you'll probably spot every day if you're in wound care. Okay. Patients miss visits that don't match the severity. Here's a key note that I've noticed my patients do. Patients will notice if you actually care. Okay. And I don't care what patients say. I don't like when it comes to that, like, oh, if the doctor follows up too much, man, that's because I care. If you're missing an appointment and I call to check on, make sure that you follow up. Yeah. Oh, I forgot my offloading device repeatedly. I don't the fact of the matter is this is an ulcer, this is our specialty, and our job is to make sure it closes. So regardless of anything, I do understand where patients lose encouragement, right? I do understand that. And that's your job too, to be a cheerleader for your patient as well. Okay. Yes. And unfortunately, some people don't have a really good support system. Some people are also by themselves. So that's even more. Make sure you even work with social work and make sure that they have the right support to when they get discharged, when they get out of clinic, things like that. Okay. Lack of urgency despite the obvious danger. Side effect, low eye contact with your physician. Okay. I just gotta do what I gotta do, things like that. Right. You'll see that. But what they say you might hear a patient say, "It always comes back." That might be true, and I try to explain to the patient it's most likely because of the osteomyelitis. It's really hard for it to have stable skin over infected bone, and you might need that piece of bone to be removed. I try to explain that to my patients. Some patients will say, "I'm tired of doctors." I understand, okay, who isn't? Nothing works. That's not true, okay, because we have a whole Disneyland of treatment options for a diabetic foot ulcer, okay? We have almost everything that we can use on a diabetic foot ulcer, okay? We have so much stuff, okay? I don't want to get my hopes up. I've heard patients say that, and I'm like, I totally understand. But as long as you have life in your body, there is hope. And that's a fact. Okay, or I've had patients even just say, "Just cut it off then." Okay, that's usually said when a patient is emotionally surrendering. They don't really, sometimes they mean it, sometimes they don't. It's just because they're emotionally exhausted from the whole system and from the whole experience of it. Because I don't think people understand, unless they're actually in wound care, how long some patients have wounds. They'll have it for years. Okay, some wound care clinics have patients that are coming on a literally on a weekly basis for the past 2 or 3 years or even longer than that, okay? But what's happening underneath? The patients stop believing that their actions actually change the outcome. And so the brain stops spending energy on action. And this is where limb salvage either becomes a partnership or it turns into a power struggle, unfortunately. So, what is the treatment plan? How do we reverse the learned helplessness in limb salvage? So let's make a controllability protocol. Now we're going to get practical. This goal is not about motivational speeches. I am no Tony Robbins, even though I love him. But the goal is retraining the patient that they can control the outcomes of their wound and their limb salvage, okay? Retraining controllability. And it happens with small, believable steps. So first, you name the pattern without shaming. I do have patients in the past that just don't follow up because they're too scared. They might not even have the right, what's it called, transportation. I will call every single patient transportation service, ambulance or whatever, and make sure they get to my patient. I would be like, do y'all take their insurance, all this jazz, because there's a lot of resources available to patients, especially in America for that, okay? So when people go through a lot of setbacks, their brain starts feeling like nothing works. And so that would make anyone stop trying, which makes sense, right? So you have to understand patients from that point of view, okay? And what you want to do is rebuild parts that you can control. So this comes in two things: normalizing the response and invite collaboration. Because the patient has to feel like they're a part of this team. They don't like to be talked about like they're a number. You have to remember their name. You have to remember what's going on in their lives, Make the patient feel like a person. They are a person. Don't ever be like, I've had patients tell me that they felt like a number. I felt like a number before in a doctor's appointment, and I never went back to that doctor. Okay? I like the doctors that remember me. They ask me what's going on, what's new with your life. They remember little things, okay? So we'll replace the big goals with micro wins, okay? So instead of saying heal the ulcer, aim for a 48-hour win. So let's say keep the dressing dry, clean, and intact for 2 days. Yay, that's a win, right? A 3-day win, wear the offloading device from bed to bathroom. Yay. And 1 week win, text a photo every Friday. Yay. Micro wins, okay, to rebuild this cause effect loop for the patient. Now, build an if and then plan for real world barriers, okay? So helplessness grows when the plans are unrealistic, okay? And I do try to be realistic with my patients, okay? Sometimes I get discouraged, especially if their wound is stalling, but I'm like, you already saw how far you came. You still got your foot. You still got blood flow. So let's do it. Don't stop now, okay? Like I said, it's a marathon, right? Like that song by Queen, "Don't Stop Me Now." Okay, so examples like, if you must work standing, then we can design a work modified offloading plan and an employer note. I do that all the time for my patients, and I make sure it's nice and bold or in caps because I don't want my patient standing for prolonged periods of time. No prolonged weight bearing, no strenuous activity, no heavy lifting, things like that, okay? Or, put them in a desk job right now. This is temporarily, okay, until they fully heal. If you can't get supplies, then you can create a backup dressing plan with what you do have, okay? If transport is unreliable, we can also do teletext, okay, or cluster services, things like that, okay? But use tech back like a limb salvage CPR, okay? Don't ask, do you understand? Ask, show me how you're going to do this at home. Like if I ask the patient to change the dressing at home, I always make sure my patient has good support system. Let's say they would have a husband or a daughter or family relative that changes the wounds for them. Okay? But teach back converts passive listening into active control. And actually patients do watch what they do. They'll be like, well, doc, you do this. I notice you paint this on and everything like that. Use gloves. Oh, and then you do that. Patients get used to it because it's like a routine in their head. It's literally you're doing it every other day, right? Give the patient choices, like real choices. So even small choices restores autonomy for the patient. Do you want morning or evening dressing changes? Do you want the removable boot or do you want the total contact cast given your lifestyle? Do you want to follow up weekly or twice a week? Or do you want a nurse at home? Control is medicine. Now, make progress visible, okay? Helplessness collapse when the patient sees evidence. So, you have to track the wound dimensions. That's why I take a photo every time. Photos at the same angle weekly. I know if anybody take my phone, they will be surprised how many pictures of wounds I have. Pain scale. Always ask the patient about that pain scale. Is it getting better? Patients even notice that, and I'm not an opioid person. I don't prescribe opioids. That's one thing I don't do because I've even had big time surgery and I didn't need it. Okay. And if you do, I do refer you to pain management, to the people who are the specialists of that. Okay. But I've had patients who've been in pain. People just be like, oh, whatever. That's because you're walking on it, right? And I'll prescribe them like an anti-inflammatory that works well for them. And they'd be like, oh, can you prescribe that again? Because it works really well. It's helping with my pain. I'm like, oh, yay. That's nice, right? And honestly, pain does get better the more the wound closes too. I've had a patient that had severe pain in both legs. Now, no more pain. She's doing fantastic, healing well. I love it, love it, love it. Okay? Steps count. Okay? So show the patient that effort equals change. Now, you also have to address the depression or the trauma directly. So learned helplessness and depression overlap often. So practical options are like a brief screening, like the PHQ or the PHQ 2 or 9 in primary care settings. Refer to behavioral health when available. Consider pain control optimization and sleep for the patient. Incorporate supportive counseling strategies. Okay. And for our listeners, if you feel persistently hopeless, numb, or unable to function, please talk to a professional, okay? That's not weakness. It's actually treatable, okay? That's what healthcare is for, okay? Add peer proof, okay? Things like saying, I've seen this work before. Patients regain hope faster when they hear success stories about other patients, peer mentoring, community wound based care groups, and family involvement with clear roles, not like policing, okay? Hopelessness is contagious, but so is hope. Hope is contagious as well, and that's the one we want contagious, okay? So, on the other side, clinicians can have learned helplessness, especially in limb salvage. Usually, we get that usually when it comes to the insurance, compensation, all that jazz, right? I've been told, no, you can't put this on because the insurance doesn't cover it, or you can't do this because the patient can't afford it. I'm just looking at them like, whatever. Like, well, I'm gonna find a way. I'm going to find a way. That's one thing about me. Gabby's gonna find a way no matter what. Okay? One time I told a person, have you ever seen me not get what I want? I'm gonna get it for the patient. Okay? That's one thing about me. I'm gonna get it for the patient. I want to make sure we get this. I don't care if I have to contact every little resource I have. I'm gonna try my best to get it for the patient. Okay? So as clinicians, we have learned helplessness too. But I feel like anybody who's been through residency, the healthcare system, we are all fighters. We know how to fight for our patients. We know how to fight back. We know how to get through it. Okay? But say things like I've heard people have learned helplessness in clinics as healthcare professionals, things like, "Oh, these patients never change." I think that's just being negative. They're not all non-compliant. Don't ever say that. We just end up amputating anyway. If I heard somebody say that, I'm going to be really annoyed and I probably have to walk away from that person. Insurance won't approve it. And what does that mean? That doesn't mean that you can't help the patient, right? We'll find ways, okay? Why bother with limb salvage? Like I said, limb salvage is not for the faint of heart. It's a marathon. It's a lot of endurance. So, you'll see people in limb salvage there. There'll be people who have real good endurance, okay? Endurance is a thing that you just have to push yourself, okay? And you have to have patience as well, okay? But condition helplessness is often built by repeated moral injury, like seeing preventable amputations. That happens a lot, okay? We see amputations that could have been prevented, but it happens because, like, delayed referrals, unfortunately, that's honestly, you're gonna see that a lot, especially in the ER, but that's what we're trying to prevent. You'll see them come when it's way too late, unfortunately. System barriers like, oh, the only person that the patient insurance covers is like 2-hour drive away and the patient has no car. You're like, what? Doctors burn out, okay? And then lack of resources, you know? S I try my best, with resources, especially when it comes to patient. You have to do your best with what you have, okay? but we can do it. Like I said, as long as you have blood, life in your body, we can do something, okay? So, how do we treat clinician helplessness? Create a standardized limb salvage pathway that reduces chaos, okay? Share wins weekly, like photos or healed cases. Debrief losses without blame. Don't be like, oh, that's because of this. Okay, let's not blame anybody. Barrier rounds. So, one system barrier per week that the multidisciplinary team can try to fix, okay? Protect time for multidisciplinary coordination, okay? So when the team believes limb salvage is possible, the patient believes it as well. Patients know when you care, okay? That's a simple thing. Patients know when you care. They know when you don't care. They know when you're just walking in and out of the room. Yeah. So learn helplessness is what happens when life teaches you that your actions don't matter. And I don't want patients to feel like that. I don't want clinicians to feel like that. Your actions do. It's called consequences. All our actions matter, okay? And limb salvage is the opposite message, okay? In limb salvage, it shows that your choices do matter. Your steps matter. Your follow-up matters. Your offloading matters. Your glucose matters, okay? Your team matters. Your life is worth the work that we put in for limb salvage, okay? We're not just treating wounds, we're restoring a whole lifestyle for you, okay? So I hope that helpful. So let's do some quick high yield board questions. I don't even know if learned helplessness is on boards, but let's just do it. So what is the core condition that produces learned helplessness? The answer is repeated exposure to uncontrollable stressors, outcomes leading to reduced attempts at escape or problem solving. Next question. Question two. Which attribution patterns increase risk of generalized helplessness? A patient integrating, or a doctor, anybody, a clinician integrating or interpreting negative events as stable, global, and internal. I think you'll see that a lot in developing countries because they're just like, we don't have the resources. This is the only thing that we can do. And that's not true. Okay. In diabetic foot ulcer care, what is the common behavioral sign of learned helplessness? Passive resignation, just do what I gotta do type of thing, poor follow through despite education, avoidance of appointments, and low initiative. What is one clinic-based intervention that directly targets helplessness? Micro wins. So let's do little micro wins, visible tracking, photo measurements, reestablished effort equals outcome connection. And then name one system factor that can drive learned helplessness in wound care, okay? Unpredictable access or delays, contradictory instructions, okay? Punitive language or shaming, okay? Denial of supplies and repeated administrative barriers, okay? So people who just like to call and be like, oh, you can't afford this, it's insurance denial. Yeah, you're actually playing a role in learned helplessness. So try to be nice, try to be helpful, tell patients, let's see what we can do to get you better. Okay. That should be in every clinician's vocabulary when it comes to wound care. Let's see what we can do to get you better. Let's see what we can do to help this close. Okay. So if this episode made you think of a patient, made you think of yourself, or made you think of the team, remember learned helplessness. Helplessness is learned, which means that we can control what can be relearned. Okay, so see you next time. This is Diabetic Foot Files with Dr. G, and take care of your feet because they take care of you.